Hi, my name is Shivn Jain, and this is my community connection project. I'm interviewing Shivn. He is a physical therapist from Long Beach, California. Through this project, my goal is to learn more about the relationship between DMD patients and their healthcare providers, specifically in the context of physical therapy. We've discussed DMD and physical therapy coming from a more biomechanical context, but I do want to get a wider perspective in what the role of physical therapy is in combating the burden of disease and how relationships between DMD patients and their physical therapists are crucial in creating and meeting their goals. So, really, just to get a stronger background about physical therapy and the role it plays in this multidisciplinary approach to care. And this is my community connection project, which will be interviewing Shivn Jain, who is a doctor of physical therapy from Long Beach, California. So I just do want to get a better understanding of the role physical therapy could play in supporting patients and their families. And so I'm glad to be interviewing Shivn to be able to understand this better. So Shivn, can you first start by giving me some background about yourself and like how you got into physical therapy?
Yeah, so my name's Shivn Jain. I'm a recent graduate from Cal State Long Beach for their Doctor of Physical Therapy program. Um, my history with physical therapy is somewhat extensive. I've had a lot of injuries myself, and I have gone through a lot of physical therapy more for sports injuries. But physical therapy is multifaceted. Um, And speaking of like Duchenne's muscular dystrophy, it's more on the pediatric side of what we would um, call physical therapy, whereas my background is more orthopedic side. But the two go hand in hand to a certain extent. So,
Perfect. And so first question would be like, why is physical therapy so important when addressing someone with DMD or other diseases that can cause progressive muscle weakness?
Duchenne's muscular dystrophy obviously is a genetically inherited disorder that typically is diagnosed between the ages of 3 and 7. Um, and that's kind of where these children start to show delayed motor milestones. So in physical therapy, we look for these motor milestones from children, and if kids are not meeting these motor milestones, whether it be walking, um, higher level motor skills like running, jumping, doing stairs, these sorts of things, it kind of gives us an idea of where we can kind of guide um, either parents mostly into supporting their children and giving them more education on what to look out for as their children age and as this disease progresses.
Perfect. So in your opinion, what are the most critical goals to address if working with someone with DMD, and how do you approach achieving those goals?
So biggest goals are to know improve the quality of life as much as possible. Because these kids are still very young, probably want to play, are falling behind as well from their peers. You want to make their participation the goal of any physical therapy activity. So, in the physical therapy world, we use what's called the ICF model, and it's broken up into multiple categories, but the three main categories are impairments, activities, and participation. And participation is what we want to focus on with these kids, right? If this kid really likes going to the playground or likes playing baseball and throwing a baseball, that's going to be the focus, is kind of promoting that side of physical therapy, because I know this disease is progressive, it is fatal, and treatments out there in terms of medical treatment is somewhat limited. And so if we can improve their participation in their activities and get families involved and friends involved, that's probably the best course of treatment for these patients. In other areas, we would want to work on their impairments as well. So if there are strength or range of motion impairments that could lead to pain, we will want to work on kind of whether it's stretching, um, different activities to get their muscles working, just to maintain any strength and flexibility they do have. Um, rather than just not addressing those things. And these patients or kids will then, become more stiff and more limited.
Perfect. And can you like describe your approach to developing like personalized treatment plans that address the unique needs and goals of individuals with DMD, particularly like
Yeah.
increasing their daily life activity?
Yeah. So the biggest thing when it comes to any physical therapy treatment, typically these children will come in with a parent or a guardian, brothers, sisters, the whole family, whatever it may be. But the most important thing is starting with the subjective interview of these patients and their families. And so getting the necessary information of one, what are the family's goals and what are the child's goals? Those are the biggest things to keep out for. And that's what you want to ask for as a physical therapist, because if you're working towards goals that they don't want to work towards, it's not going to be a cohesive treatment experience for these people. You want to make sure these parents are educated, and even the child, depending on the age of the child, if they're like in their teens and they know more about Duchenne's muscular dystrophy, they have an idea of what to expect. Where if it's a younger child, it'll be hard to educate them on. So educating, getting goals from the patient and the parents will help guide this treatment to help them meet their goals. So if this kid wants to, participate in sports activities, okay, right? Most of these kids lose the ability to walk before their adolescent years. And so how can we get these patients to participate in sports? There are adaptive sports, there are adaptive equipments, so we can connect these patients with the people who have the resources to provide those adaptive equipments and get them into sports and continue their sports, right? Along the while, we're helping them maintain their strength of their upper body as much as we can, so that, and making it fun, integrating sports, making it participation specific or activity specific for these patients to keep it fun for them, and help them work towards their goals of, for example, playing sports. If the family's goal is we want it easier to help him get in and out of their wheelchair, okay, then we'll do family training, right? So we'll help the family train, we'll help the patient train in terms of getting in and out of their wheelchair or being more higher level, doing higher level things as much as we can, right? Obviously, this is a progressive disease and we want to, monitor that frequently. And so we want to just facilitate whatever the family and the patient want.
Perfect. And kind of along that lines, like what can specific things does physical therapy provide for the patient that other modes of therapy or health care can't?
A good question. So for the most part, I'm not an expert on what other professionals offer. But what we do is look at the patient from a movement standpoint, right? And every human, to a certain degree, participates in movement every day, right? Whereas, someone who's maybe an internal medicine doctor who's really prescribing meds for these patients, they may not be, so inclined to comment about the movement and what's essentially impaired in this patient in terms of their musculature or their range of motion. And so we can do a full body assessment to see what areas are weak, what areas are stiff, what areas can still be improved upon. And so my expertise comes in to make sure that this person is still functioning in a way that they can function throughout their daily life. And so if I see that, maybe this person that has DMD is already in a wheelchair, already has a mobility system at home, but their upper extremities are still strong. Okay, we're going to work with that, what we have, right? Maybe they're lacking a little bit of flexibility. Okay, we'll try to work towards improving flexibility, but maintaining strength in the upper body so that they can do whatever they can with that upper body while they still have it, right? I know that the legs are going to be hard to maintain. So we'll give a home exercise program as something we can do for the family and the patient so that they can maintain what flexibility or strength they do have. But to a certain degree, we want to focus on what they currently can improve upon. from a movement standpoint.
Awesome.
We
Um,
also, as physical therapists, spend the most time with patients out of any healthcare profession. And so this is good to understand like what the family dynamic is and how these kids will, go about their daily lives. We can get to know them a lot better rather than, I can't comment on exactly how long doctors or nurses stay with these patients, but we'll spend at least an hour with them, right? Maybe 1 to 2 times, even 3 times a week, depending on what is available through insurance or what the parents can afford or what the state covers in terms of state-funded physical therapy. But we do spend quite a bit of time with these people to get to know them, to get to see what they want to do. And it just helps the overall psychology aspect of it as well as the movement aspect.
yeah, and kind of going along with that, like how does your role of a physical therapist kind of transcend beyond alleviating pain and discomfort? You kind of went into that, but
Okay, yeah. So um, yeah, once again, it starts with, understanding the individual coming in unbiased is a big thing that is a part of our um, kind of conduct of care and conduct as a physical therapist. It's a blank slate every time someone comes into your office. So, getting the whole story from the patient, right? Understanding what they've gone through. And in this case, DMD, you got to think about the parents and the family as well. And so you're not just getting information from the kids, but also from the family, right? The family's gone through a lot, right? Their child now has this progressive muscular disease, and they're probably dealing with a lot, and so it's kind of touchy. So you have to be a good listener. You have to know how to, one, be empathetic and sympathetic about what the family's going through, but at the same time you still have a job to do, right? And you have to be realistic, right? You can't just say, oh well, we're just going to fix this person, well, because that's not possible. So you can't say those things. So you have to have that empathy, but you also have to be realistic. So you have to consider what everybody's mental capacity and emotional capacity is. We're also good facilitators as well. So if we notice something, like if there's some psychology or psychologic things going on, or if there's what we call yellow flags, whether it's depression, anxiety, that sort of thing, we can help refer. So since we do spend the most time with these patients, we get to see these patients a lot, right? So if there's issues with um, anything of that nature, we can help refer. We can be like, okay, well, I've noticed these things. I want to help you get these things figured out. We're going to refer you to this psychologist or this therapist here. Or if I notice any like hand things, like really fine dexterity, fine motor things, and I notice that from a movement standpoint, I can refer this person to a different therapist that may help them work with their hands more, maybe occupational therapy as well. And so the time we spend, we get to see a lot more and hear a lot more. And so it helps us facilitate other options of care as well.
perfect. Yeah. So there is kind of like a collaborative, or at least like you have to be in communication with different modes of healthcare, psychology. Um,
Yeah, I would think so, especially with these families. You know, it's not just they're not just seeing a physical therapist, right?
right.
There's going to be medical workup, there's going to be pharmacology, so they're going to have a pharmacy. So you'll have all this information as a physical therapist as well. You can ask for the medications, you can ask, which doctor they're going to. And if you start to see other signs, like the yellow flags is a big thing, like you can say like to the parents, like, hey, like Johnny or whoever is really going, is he seems more depressed lately. Like maybe you guys should facilitate, and then we can get that information and give that to the parents so they can help their child, right?
Right.
Or even for the parents, if you notice the parents are having a really hard time, you can also say like, hey, like if this is really hard for you to come to therapy 2 to 3 times a week, you got your doctor's appointments on Fridays, you have to work, all that, take a break.
Right.
It's not just you have to always go to the doctor, you always have to get physical therapy. Because we're seeing those patients so often, it's kind of facilitating how they're going to move out through their life, because ultimately they're not going to be in physical therapy their whole life,
Right.
right? It's not just the system doesn't work like that. So we have to know when to stop therapy as well. And we want to give the family and the child as many tools as we can so that they can maintain and even potentially maybe even progress themselves as they go through physical therapy. So it's always kind of like a give and take with physical therapy as well as with the family, understanding what the family needs and just being alert while you're treating these patients and their families to notice if they need anything else than physical therapy or medical management, whether it's a psychiatrist or psychology or therapist or, occupational therapy, things like that.
Are there specific strategies that you have for involving and educating family members or caregivers of individuals with DMD?
It usually starts within sessions is when we give most of our patient or family education. And education can be anything from educating them about the disease itself, which they may have gotten a lot of education at this point, but maybe not from a movement standpoint.
Right.
Like the doctors may just say, oh, this is a genetic disorder that's going to make their muscles kind of, really, really weak. And basically that's all they know. But from our standpoint, we can say like, okay, this is the typical progression. This is what you'll see. They're going to progressively get weaker through the legs mainly. They're going to stop walking and then it'll get into the shoulders and then it'll turn into progressive weakness into the hands and that sort of thing. And so we can educate more on the muscular progression. We can also educate on, that's the disease itself, right? Then we can educate on why we're doing what we're doing, right? And this is as we're doing it. Like if they come in for a session, I want to stretch the chest if they're sitting really slumped, right? And I want to teach the family how to help stretch if the patient themselves can't get themselves into the position. So that's also education, is teaching the family why we're doing what we're doing, to stretch out certain muscles to get more range of motion. Maybe Johnny wants to be able to throw a baseball and he has to get himself up, right? So the family can help with that, right? But then there's also handouts, things I can send home, I can print out, right? And then if myself, as someone who isn't specializing in pediatrics and the family's uneducated about where they should go for physical therapy and they come to me, I will probably educate them on that. There is someone better to help them through this process, probably a pediatric physical therapist.
Got it.
The other thing, a lot of things families don't know about is the state and government access to physical therapy as a child, because a lot of these people may be underserved, may not have good insurance, may not be able to go to the best places.
Right.
And there are different options for them. And so I could educate them on the option instead of having to pay out of pocket. They could go to nonprofit organizations that have pediatric physical therapists that will be able to help them as well, and they wouldn't have to pay anything for that. So there's a lot of education that can be given to these families so that their loved one gets the best care that they can get.
Right. Awesome.
And whether it's email, printouts, verbal, it's all education.
Right. And kind of on that note, you're mentioning access to healthcare and insurance and stuff. Do you have to take into account health disparities when treating patients? If so, what are your strategies with dealing with that?
Yeah, absolutely. So, from my point of view so far, I've had to deal with patients on Medicare, which is the older population. I've had to deal with patients on Medi-Cal, which is kind of the underserved, low income population, patients with PPOs, not necessarily HMOs, and then cash paying patients who actually don't have insurance and they're paying cash, right?
Right.
And so someone may come in and they can't afford a copay, right? Or they can't afford 2 times a week, but they can afford 1 time a week, right? And their copay is $75. So if they're coming in 2 times a week, that's $150 a week.
Right.
And if the doctor wants them coming for 6 weeks, that's 150 times 6, which is $900.
Yeah.
And so that becomes expensive, right? And that's just the copay. That's not what other costs that they may have. So if they can't afford that, I as a physical therapist, I'm not going to be like, no, you have to come. I want your money. That would be not ethical at all. And so for people who maybe are lower income, I would kind of tell them to, hey, maybe focus a lot more on your exercises and doing things at home with whoever can help you, and then come see me in a month. And then that would be $75 a month, right?
Right.
much less cost, but they have to really be on top of things.
Right.
Or what I can do for children, it's different. So children, you can have other locations. So say this kid with DMD goes to school, right? He can
Right.
actually get physical therapy at school. So if the parents don't know this stuff, and they don't have the time to bring their child to an outpatient physical therapy, you can
Right.
actually get physical therapy through the school. So if say they don't have a car, they have to take a bus and they can't get to physical therapy, but they came to us for one visit and it took them 2 hours to get there, I would consider that a healthcare disparity, right?
Right.
They don't have access to
Exactly.
transportation, they can't get there, and maybe the cost is too high as well. Well, I'll educate them on the fact that they can get PT through the school.
Got it.
As their pediatric physical therapist, I would probably contact and look into the school district and help them through that process as well. I wouldn't just leave them hung out to dry, like, oh, no, 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 the school can take care of it. Go check with the school. It would be more helping them through that process and getting them transitioned to that level of care,
Right.
right? Or getting them hooked up with a nonprofit or a government-led, um, government-funded program through either the Department of Health, that sort of thing. California Children's Services is also available in California. And that's typically available till they're 21 years old.
Got it.
So when you're 18, you're still, even after 18 to 21, you're still considered pediatric. And
Right.
so people with DMD would fall into this category because of the progressive nature of the disease.
Right.
And so it's not just the child themselves that are at a healthcare disparity, you have to consider the family as well,
Right.
because these people are probably aren't transporting themselves. So
Right.
it's
Right.
just kind of figuring out what they need as a family and a patient, what they can afford, access to transportation, um, even like language barriers are sometimes a big
Right.
deal.
Right.
And so say, if someone speaks Korean, I don't speak Korean,
Mhm.
and it'd be really hard to get a Korean translator outpatient. So maybe I would facilitate someone to go more hospital-based pediatric clinic, like Miller's Children's
Right.
Hospital in Long Beach has an outpatient clinic, and they have translators, video translators on site. So that would be a lot better option for care for them if we can figure something out with that.
Got it.
Mhm.
Awesome. Thanks. And then you mentioned participation being one of the most important aspects in trying to increase quality of life for DMD patients. And you did mention some like assistive devices, equipment that you'd use or recommend to these individuals to enhance
Mhm.
mobility, independence, ability
Mhm.
to participate. Could you just provide a few examples of those?
Yeah, so the biggest thing is probably a wheelchair.
Right.
Not just a manual wheelchair, but some sort of powered wheelchair. Because the first thing, you want them to do is to be able to move around, right?
Right.
But you also want to give them the ability to move themselves around, right? And so
Right.
if their arms are still pretty good, they'll probably start out with a manual wheelchair. But to a certain extent, you start to lose a lot of muscle in the proximal areas, like the shoulder girdles, and it'll be really hard for them to push a wheelchair.
Right.
So getting a power wheelchair is probably the best thing for them, um, especially when they can't walk. Other than that, I mean, if you're really in the early stages, I mean, the biggest thing is to keep the participation high and just trying to limit the amount of devices as much as possible, because then that kid seems like they need the devices. But at the same time, it's kind of like a gray area. It's like if they can't keep up with their friends, if they don't have like a supported walker or something like that,
Right.
then you got to get that for them so they can run with that
Right.
support, right? So, um, and so there's a lot of other devices that like kind of facilitate like balance and postural control so that we don't have a high risk of falls, but these kids can still get around. Um, you have to think about what the family needs too, right? So as DMD progresses, and these kids are living older, maybe they're like 16 years old, but they still weigh like 120 pounds, right? A
Right.
parent's not going to be able to lift them out of the bed,
Right.
right? A full 120-pound person that can't help, right?
Right.
That can't stand either. So if that's the case, you may need to consider, getting like a Hoyer lift um, for the patient's parents and family members to actually lift them out of the bed. It's like a motorized like lift.
Mm-hmm.
And so it really depends on what the family and the patient needs, right? Because if they're higher functioning, they don't need that Hoyer lift. The patient can help with their arms to a certain degree, but as they get progressively weaker, they won't be able to move by themselves, and so then they'll need assistance. Where caregivers can come in handy, but typically it's the family. They can't afford a caregiver, and caregivers really, it's hard to get them covered with insurance. So you may need a lift to a certain degree.
Got it.
And then if they're
Okay.
in a power wheelchair too, where are you going to put the power wheelchair if you need to go to like a baseball game, right? So you can't just have a normal car. You have to have like a accessibility, like
Right.
a minivan or something like that, so they can actually wheel into the car. So it goes beyond just the equipment needed for the person with DMD. The
Right.
family needs equipment too.
Right.
Yeah.
Okay, perfect. Just my last question is, um, when dealing with these kinds of patients that are experiencing progressive diseases, progressive muscle weakness, are there particular challenges that you have faced or anticipate facing?
Yeah, I think just knowing that the patient's going to get worse is probably the hardest thing as a physical therapist.
Right.
Um, so dealing like with the family and just maintaining that confidence that you are helping this family to a certain extent,
Right.
even though this disease is progressive and fatal,
Right.
right? So ultimately, as a physical therapist, you want your patients to get better
Right.
and you want them to prolong their health. Unfortunately, in this case, that is not 100% possible. We can prolong quality of life and improve quality of life, but we may not be able to prolong their length of life from a physical therapy standpoint,
Right.
if that makes sense, because it's
Yeah.
progressive, right? And so, um, that's probably the hardest thing I foresee dealing with this. Um, I could also see, the family potentially getting frustrated.
Right.
Maybe their son or is not showing, or a child is not showing progression
Mm-hmm.
with improvements. But that's really where you have to set up and educate the family prior to starting physical therapy and being on the same page as to what physical therapy will do for their child,
Right.
right? If I broke my arm, or if this I came in or a kid came in with a broken arm and their arm was weak after, but they had no other health problems, the kid's eventually going to get stronger and their
Right.
arm's going to be fine in the future. But for a child with DMD, you really have to get the patient or the family to understand why physical therapy is important. It's to facilitate participation, improve quality of life, facilitate family interaction, maybe family treatment, that sort of stuff. But they have to understand that this disease is progressive, and medical management, as much as their research as they're doing to try and find a cure for DMD, that's going to be that side of it. We're going to be improving mobility and helping the family and child navigate their mobility concerns.
Right.
So I think that would be the hardest thing.
Got it. Yeah. Okay, perfect. I think that was all my questions. Thank you so much for your help. Really learned a lot.
You're welcome. Thank you for having me.
Yes, thanks. So, the goal of this interview was to really break down the role of therapists in treating DMD and how they kind of fit into this multidisciplinary approach to care. Through this interview, I think the main thing I was able to learn was how crucial it is for physical therapists to develop personal relationships with DMD patients and their families. It seems like it's super critical for improving the quality of their lives by talking extensively with these patients and their families. The real role, I think, of physical therapists in this context is to allow DMD patients and their families to have as much control of their lives as possible. Through things like integrating fun exercises into therapy sessions, making sure DMD patients can keep up with their friends, return to sports, or even helping families get access to less expensive care, educating families, things like that. Physical therapists can really play a central role in knowing their patients, connecting them to other modes of care, and also really trying to reduce this daily burden of disease so their lives can stay as normal as possible.